Welcome to Insights, brought to you by ManCC Cancer Center. Insights is a multi-series podcast of cancer-related subjects, giving perspectives from specialists and cancer patients as they tell their real-life stories of victory, such as Sharon.
I'm Sharon Blake, a breast cancer survivor. I want to share my story of the most challenging and rewarding journey of my life. I hope you find these podcasts full of wisdom and inspiration.
The complete Insights series may also be viewed at ManCCcancercenter.com. Welcome, everybody, once again to Sharon's Insights, a series of podcasts sponsored by the ManCC Cancer Center. And I'm joined, of course, by the aforementioned Sharon. That is Ms. Sharon Blake. Hello.
Hi, how are you?
I'm quite well. How are you doing today?
Good, wonderful.
Outstanding. And our expert today that's going to be talking a little bit to us about surgical options for breast cancer patients is Dr. Samir Hassan. He is a board-certified general surgeon. He's a fellow with the American College of Surgeons and a specialist in breast cancer surgery, and his business is the ManCC Surgical Specialist. Thank you, Dr. Hassan, for being here.
Thank you.
We're delighted to have you, and with your level of expertise, I'm sure that everybody's going to get a lot of great insights as it relates to breast cancer surgery options and things like that as we go forward. Before we begin with that, I'd like to have you tell folks a little bit about your background, where you got your education and things like that.
I got my education in Egypt, where I was born, and I got my medical degree in '65, and I went to England for further training until '73.
Okay.
Then I went to Detroit for more residency in general surgery. I have been in general surgeon since '77, and my wife, which was a nurse, I met her in England during training. She developed cancer age 34, and eventually, after all the trial and treatment, she passed away in '86 Christmas Day. And this made me more interested in the management of breast cancer, particular interest in it. My background in general surgery was particular interest in the management of breast cancer.
Wow.
Yes.
Wow, that's quite a story, Dr. Hassan. What are some of the surgical options that are available to ladies today as it relates to breast cancer?
Nowadays, with more emphasis on conservative breast cancer surgery treatment. Breast cancer, as you know, was mentioned the word cancer because the Greek philosopher went to Egypt in thousands of years ago, found in the temple and described in some of the Egyptian women as a tumor with mass in the breast, and looks like the crab animal, and so henceforth describe it as cancer. And then the British took interest in the management of the breast cancer. The treatment at that time was to remove the lump, and this ended by more than 50% of the women pass away, not successful. Until British surgeons in the early 19th century discovered, after evaluating several thousands of breasts, that is, there is multiple spots in the breast in addition to the main spot, called the multicentric theory. Since then, an American surgeon was visiting Europe, Halsted, and Halsted heard about this finding, so he did the radical mastectomy. And for the first time, women with breast cancer survived and the cancer. But radical mastectomy means removing the breast and the muscle, disfiguring and the lymph glands, and disfiguring the patient, but she survived. And this was the standard of care until the Second World War, when another Scottish surgeon, Patty, and he modified the Halsted operation by saving the muscle, and this is called modified radical mastectomy. Until the 80s, whereas Bernard Fisher, the American surgeon, and researched and did, of course, as you know, it takes 10 years to know how many patients will survive and do good, alive and well. And he said, why do we remove the breast? We remove the breast because of the multicentric spots. He said, no, we can remove the lump and radiate the breast. Yes, but the radiation can cause problem. He said, no, nowadays we have computer, we have simulators, and we can get the results. So they did that for 10 years, and what found that is for a smaller tumor, less than an inch or so, if you remove the tumor and you lumpectomy and you radiate the breast and you follow it up for about 10 years, the result is as good as removing the breast, and that was great achievement. And that was the standard of care nowadays.
And when was that developed? At what time? In the late 80s?
In the 80s, yes.
Okay. And of course, that's quite an amazing story, actually, how the whole thing went from one stage to the next, and that is the standard of care. Where does it get to a point, though, in your analysis of something, maybe when you do a biopsy or otherwise, where it goes from that shorter stage, if you will, with a lumpectomy with radiation, to saying this has spread much further? When do you have to go to that next level of going for a full mastectomy?
Well, usually if the tumor is too large, nowadays we give chemo radiation called neoadjuvant.
Neoadjuvant, okay.
Neoadjuvant. And neoadjuvant, it is combination of the work of the oncologist and the radiation oncologist and the hematology oncologist.
Okay.
And this will be like for about 3 months, 4 months. Mm-hmm. It shrinks the tumor to make it more amenable to a lumpectomy or partial mastectomy or quadrectomy or whatever they call it. The slang word is lumpectomy, but the word is used, we use it partial mastectomy.
Okay, and you just said, what was one of the other terms? Quadrectomy? What did you just say?
Quadrectomy or segmental resection.
Okay.
It is like, imagine it's rounded, the breast, and you remove a segment of the area of the tumor with safety margin in it.
Okay.
Now, there is some tumors which is very large, and the breast is small, and whatever you shrink it, even if you do lumpectomy, you're going to disfigure the breast.
Yes.
The end result will not be aesthetically good.
Yes.
So you offer to the patient is to remove the breast, and then you can have the collaboration of the plastic surgeon to put a tissue expander for later on having an implant put there and adjust the breasts. Okay. Some patients also, you have to respect the wishes of the patient, but you have to educate them.
Yes.
And they respect the wishes. Some of them, especially here in Florida, prefer that I don't want to bother with lumpectomy and radiation. I don't want to go every day for 6 weeks. Just remove my breast. But you have to try to educate them, because old habits take long time to correct.
Sure. Absolutely. Well, as you said, it's taken so long, historically, as far as how the treatments have changed.
Right.
Now, Sharon, why don't you talk to Dr. Hassan a little bit? I know you want to ask him a little bit about your specific situation.
Yeah, he was my surgeon, so we know each other well.
I'm sure.
Did you see that look?
Yeah, that was quite a look. Well, and you said you also work with him a little bit as well, right?
Yeah, at the hospital. In my case, everything came back benign. Remember?
Yeah. Well, when you have mammogram and ultrasound of your breast, and done in October 2010, and the report was benign. Mm-hmm. There is no mass. Ultrasound, no mass. You came and we felt your breast, feel only thickening of the skin in the left breast. Diffuse, and the opinion was at the time that is, let us just repeat the ultrasound and the mammogram in 3 months to 6 months. But then you went away and then you came back in 2 weeks or something like that after Christmas, because you came at Christmas time to me.
Yeah.
And then after Christmas said, no, I don't like this left breast there. We feel it still no mass, no lump, nothing, except thickening. It is her breast, and she feels there's something different than used to be.
Yes.
But we are examining breast and trying to feel lumps, and we've been examining breast for all these years. Cannot feel any lump. The mammogram is negative. We reviewed the mammogram with other radiologists, and all the ultrasound negative. So I said, let us go and do biopsy for this breast. And we did the biopsy, and I found it a very aggressive cancer, a type called mucinous cancer. So we talked to Sharon, and Sharon immediately said, remove more my breast and the other breast. So I tried to convince Sharon.
So you were diagnosed with having it in an aggressive form of it in your left breast, and then you said, just do it, take them both away. Now, what was your recommendation at that time?
Well, when I did the biopsy, I said, let me excise. As I'm cutting in the breast, I can see change in the look of the tissue, but the feeling is not solid at all. But the look of the tissue different.
Okay.
And so I removed the area which I thought is not really looks very healthy. And as I removed it, it was at least 7 centimeters, which is over, which is about like less than 3 inch.
Yes.
And size of a tumor. And what happened is that was cancer, and even the margin was involved in it. And so this breast, I said that we need to go and see if she is candidate for neoadjuvant chemo, which we talked about before, chemoradiation. So I sent her to the oncologist and to the radiation oncologist. And Sharon came back and said, no, I don't want this breast. I want the breast to be removed, and I want the right breast to be removed.
And that was under sort of, you thought it was maybe more precautionary, or what was the motivation for you at that point?
You don't want to know.
Well, I mean, I kind of do. I'm just wondering what made you wonder.
There was a 35% chance of it coming back in the right breast, and I didn't want to go through that again.
Sure.
And then I thought about it as a woman. I can get a smaller, perkier pair.
Sure.
I'm getting old. Who cares?
It's a great perspective on it.
You have to look at it that way.
Of course,
but
okay.
If you got a chance of it not coming back, then just get rid of both of them. That's my, and then I've talked to women afterwards that they wish they would have got rid of both of them instead of just the one.
Interesting.
So.
And what is your as a surgeon who's been doing this for so many years? Is that a common thing? Let me ask a two-part question. Is it a common thing for women to feel that way? And what is your recommendation in terms of that? Do you feel that, again, if there's such an aggressive form of it in one breast, it's more of a recommended thing to have both removed at that time, or what is your thought on it?
Well, lately we have getting a younger woman who has the same problem, even less size tumor, even less aggressive than Sharon, who, because of their family background, like sister or mother or maternal side, the mama side of the family, who has cancer, or not even that, but mainly that, they would like to have both breasts removed and have an implant put. And we sent Sharon to a plastic surgeon, and she...
You're laughing, Sharon.
I didn't like him.
You didn't?
And she did not...
Well, there's plenty of plastic surgeons, right?
Yeah, of course. I told her the idea that is, let us, okay, Sharon, if you insist, we remove the other breasts, but maybe try to have an implant, or talk to plastic surgeon, see what is there on the table, what's there out there, and maybe can benefit her.
Yes. Okay.
But she declined. She went and so, but decided.
Yes.
But he was the one who said that it wouldn't be advisable because I was going to get radiation.
Yeah.
So.
Oh, okay. Oh, I see. Okay. Wonderful. I'll tell you what, we're going to take a quick little break, and when we get back, we're going to talk a little bit more about some of the effects of one over, let's say, a lumpectomy over a mastectomy, and some other things as well. Okay. Great. We'll be right back. Welcome back to Sharon's Insights. I'm Mike Cradlack, and we're here with Sharon Blake and Dr. Samir Hassan. He is a board-certified general surgeon and a specialist in breast cancer surgery. Welcome back again, folks. I wanted to talk to you for a moment, Dr. Hassan, about proper diagnosis and the role of the surgeon as it relates to breast cancer.
Well, diagnosis of breast cancer or breast tumor is a multitask affair, you know. I mean, it starts with the patient herself. Patient has to do self-breast exam once a month, both in the shower, in front of the mirror, and laying down.
Okay.
And we can talk in one sessions about how to do breast exam and all that. But usually we explain that when the patients come to us about how to do it in the shower. It's easy there, and in the mirror to be sure that the nipple is the same level and there is no dimpling and no anything abnormal. Don't do that every week. Don't do that every day. It is like you have a plant and you did not see the plant for 1 month. Then you notice there is something changed, new flower, new branch. But if you see it every day, you'll be deceived to notice changes. So I always do the breast exam once a month.
Okay. And actually, Sharon was mentioning something about that. Touch on that as we just spoke about it a moment ago.
I lived in Maryland before I came to Florida, and the local TV station was Channel 9. And the 9th of every month, they would tell women to do their breast exams. So
there was like a nice mnemonic as far as a date or a time. I mean, so you would recommend to somebody to say either put it on a calendar or cue it on your phone or something like that as a reminder?
Like the last Sunday of the month or the first Sunday of the month. And that is the first. Women age 40 and above have to have mammogram, at least a baseline one, age 40. Now, if you feel a lump before that or anything suspicious or abnormal before age 40, you have to go to your doctor to be evaluated and examined. Don't think it is going to go away. Let the doctor decide if this is something going to go away or not. But go and check, because this belief of going to go away lead you to miss. I seen cancer of the breast age 27.
Wow.
And so I can say that is, and in the 30s. So it's not because you are young, that is, you cannot develop cancer of the breast. So mammogram is very important. Remember that is, when I was training in Detroit, that is where zero mammogram or mammogram was developed in 1973, in the early 70s. And in the best hand of the doctor who developed it, is mammogram will give us accuracy of 85-87% accuracy, which means that is 15% or a little bit less will tell you don't have anything and you do, or you do have something and you don't.
Interesting.
So mammogram alone is not enough.
Right.
Nowadays, they developed advanced mammogram called synthesis mammogram.
Say that again.
Synthesis mammogram.
Synthesis mammogram, okay.
And that is, I think, the one unit is available in one of the local hospitals here.
Okay.
Which is like tomography or like slicing the breast by the computer, advanced mammogram. So you can see from the skin all the way to the back of the breast in the films itself, and that is very advanced one and more accurate one.
Well, it would have to be, sure.
It's expensive but more accurate one. So mammogram is important. The other one is ultrasound, because not all the lumps you find in the breasts are malignant. They can be a cyst, can be a benign lump. As a matter of fact, majority of the lumps of the breasts are benign.
Interesting.
And so ultrasound will tell us if it is solid or it is liquid, so it is cyst.
So, and now the difference, touching on that, solid or liquid, is which one would be more likely to be cancerous, I suppose?
Well, the liquid one, majority of it is benign, which is cyst. The solid of it, majority of it is still benign, but there is cancer also appear. We don't want to wait until we found it in ultrasound. We like to wait no longer. We like to see the mammogram with sophisticated, advanced digital mammogram. We can see small speckle of cancer, smaller than the size of Uncle Ben rice.
Wow.
And once we get it smaller, the smaller we get it,
Yes.
the better the outcome.
Right, early diagnosis.
Early diagnosis.
Okay,
yes.
so Sharon, you were
I
gonna
got
ask?
a question,
Yeah.
especially for my case.
Yeah.
I had my mammogram and ultrasound benign. 2 months later, another ultrasound benign. And then we weren't going to do anything until until it started to hurt, where we know that cancer doesn't hurt. So, I mean, if there's another woman out there who's going through the same thing, she's just got to push and make sure that something does get done.
That's correct. That's correct. That is, the patient has, if she feels that her breast is not the same, she feeling not the same, she's the one who feeling her breast once a month or the shower, and she noticed there is something changed. What happened is that if you have, to simplify it, if you have potato and you have parsnip and you have radish and you cut it to square and put it together and you take a black and white picture for it, it will look the same. So if your breast was black and white pictures, the tumor itself, the same density of content of water or content of fibers is the same like the surrounding tissue, then it will deceive as there is nothing. And if the echo of your breast tumor is fleshy, is the same echo like the rest of the breast, then it will deceive too and give you false reading. So it is combination, but not by, you cannot be dogmatic and say, I cannot feel it, I must be right, the patient is wrong. You have to always listen to the patient, and always, if you cannot do anything at the end, go ahead and do biopsy.
Absolutely. By the way, again, this podcast and this whole series is sponsored by the ManCC Cancer Center. If you have more questions, please contact ManCCCancerCenter.com, go to their website, and find out all this information and everything else, and how you can get a hold of Dr. Hassan and Dr. Nadaminti and Dr. Koshi and everybody else that's involved in this wonderful series of podcasts that we've been handling. A question for you, Dr. Hassan, is how do women manage breast cancer? How is it managed once it's diagnosed, and or if surgery is the option? Where do they go from there?
Well, I didn't talk about the last one, which is the biopsy diagnosis.
Right.
And the biopsy
Please.
nowadays, we do biopsy by needle biopsy.
Okay.
Needle, there used to be like, we do fine needle aspiration with a very fine needle, but they found the accuracy is not as good. So the modality now, the standard of care, is needle core biopsy, which is a little larger needle, and you take smaller, like the hair spaghetti type, shorter segment, and that course you can take it and send it, and if it is cancer, then it will be analyzed by the pathologist about what is the hormone content and activities of the cells and other tests. Once we establish this cancer, we have to know what kind of cancer.
Yes.
Is it early cancer? Is it precancerous like ductal carcinoma in situ? Or is it aggressive cancer? Is it from the lobule or from the duct? Or it is like HER's mucinous cancer diffuse? Is it other cancer which is spreading, called inflammatory cancer, which is very aggressive?
Yeah.
And luckily it's not her case. And so once we know the type of cancer and there is modality of it, stereotactic biopsy, ultrasound-guided biopsy, and also excision biopsy. Nowadays, we are more to the needle biopsy than the excision biopsy. But excision biopsy means opening and taking a piece. It still has a place, but a shrinking place in the diagnosis.
Yes.
Then we sit down with the patient and talk about how we're going to handle that.
Yes.
Usually tell them that is, you have got, this is my practice. I don't tell them, hello, in the phone, you have cancer, and then hang up. We don't do that.
Of course not.
So we have to face the patient and tell her, you come, regardless of the result, we bring somebody with you.
Yes.
Well, Sharon came by herself alone.
That doesn't surprise me at all, Sharon. Why did
I
you?
wasn't expecting anything, that's why.
Oh, but they told you to bring somebody, and you, of course, you just decided not to.
Always have to bring somebody.
Yeah.
And she sat down, and her tears came in her eyes, She didn't scream or yell or anything, just tears coming in her eyes.
Yeah.
And we told her to bring somebody else. And usually we tell her, you have cancer, we can do this and do this and do this. But it will always go from this ear, go to the outside ear.
Yeah,
of course.
They only will remember the word cancer,
Yes.
the big C.
Yeah.
And so we tell them to come back again, and we're going to talk more again about what you have and what's your options.
Yes.
And the option is either save the breast or remove the breast.
That's the options, right?
And in both options, save the breast or remove the breast, we will have to check the status of the lymph gland.
So that's the next. Once it's been diagnosed,
Yes.
that is the next stage.
Correct.
Okay.
Now, we check the status of the lymph nodes by, once the patient decide, and we encourage the patient to do less surgery, depending about the size of the tumor, the location of it. Also, a 5 millimeter, like an 1.5 inch tumor or 2 inch tumor, we're going to shrink it down to 1 inch.
Right.
In a very, very small breast, the outlook will be very not nice at all.
Right. No, but in your case, that was not the case, correct?
No, he's going to say something. Go on.
And her breast was very huge,
Right.
very large. But her tumor,
He's so bad.
but her tumor was more than 7 centimeters.
Right. That's significant.
So
At
you could
least
tell I had
3
big
inches.
boobs.
The tumor,
Yes. Yes.
Huge tumor. And we tried with Sharon a lot about adjuvant, and she made up her mind that that's the way I'm going to go, and we have to respect her wish.
Of course, absolutely, and that is as a surgeon, as a doctor,
Yes.
that is the thing. Ultimately, it is the patient's decision whether to have the surgery or what level of surgery. Correct.
Correct. I have to talk about something that is, when we remove the breast, usually when we clean up the lymph glands, used to be developed, lots of patients develop swelling of the arm, called lymphedema,
Yes.
or swelling of the arm. And they disfigure, discomfort, annoying. So until the 90s, when I think developed the sentinel lymph node mapping. The sentinel lymph node, sentinel means first. So if we identified where the cancer go, to which gland,
Yes.
and we take this gland out,
Yes.
and we test it while the patient sleep, if you find there is no cancer in it, then we don't need to remove unnecessarily lymph nodes.
Right.
And that will save the complication of developing swelling of the arm,
Yes.
lessen the danger and complication of the surgery.
Sure.
And so the standard of care now is that we do sentinel lymph node mapping. Matter of fact, I went for training for that. I went to the Moffitt and spent some time to train about how to identify the sentinel lymph node and how for limited surgery. And remember, that is when we finished my medical school and finished residency. All these concepts are not available until you develop, so you have to keep up to date with what's going on there.
Sure, of course.
Yeah.
Always continuing education
Correct.
for the surgeon.
Right.
Well, listen, we are unfortunately out of time. This has been such an amazing topic. I feel like hopefully we'll have another opportunity to speak to you about some other specific things as it
Sure.
relates to surgery. We appreciate your time,
Sure.
Dr. Hassan. And of course, Ms. Sharon, we always appreciate your insights and
welcome.
your spirit and humor. You always bring such joy to everybody that you come in contact
Well,
with,
thank you.
myself included, of course. And again, we appreciate your time. Thank you, Dr. Hassan,
Thank you.
for everything. And have a wonderful day, everybody. Again, this is the series of podcasts sponsored by the Manatee Cancer Center, manateecancercenter.com, and Sharon's Insights. So please join us again another time. My name is Mike Kradlak, and thank you very much. Thank you for listening to Insights, produced by the Manatee Cancer Center. For more information on upcoming podcasts, visit www.manateecancercenter.com.